Our next speaker is a bit of a challenge to introduce, and so I volunteered to help out. Harvard doesn't offer a degree in Richard Levins studies, but that will eventually come because Dr. Levins has made contributions throughout in much of not only public health, but in biology, many different areas of biology, in philosophy of science, and his primary identity these days is as a mathematical biologist and ecologist. And I can just say that to sit through a few lectures of Dr. Levins in a class on looking at the numerous contributors to health is to learn about the entire world. Now, it sounds like difficult to live up to, but I don't think that's the case. Now, because he spends some time in Cuba every year, he has very kindly agreed to talk about Cuba's success in its health system, which earned Cuba's leader a special award from the Director General of WHO at the time that Julio and Tessa and I and others here were there. It's really a one-of-a-kind experience, or achievement, I should say. And without any further ado, except to say how grateful we are that you're Richard just came back from Cuba, so we're grateful to him for turning around so fast and coming up to speak on this subject. Richard Levins.
Well, most of what I'm going to talk about seems to be irrelevant to the interests of this meeting. We don't have a problem of bargaining with the pharmaceutical companies because there's no private pharmaceutical industry. We have no problem of for-profit hospitals because there aren't any. There's no private medical practice. There's no medical school tuition and therefore no post-graduation debt. What you do is serve for 2 years in rural areas. There's no horde of administrators trying to decide which insurance program to assign each aspirin. So a lot of the problems are really of a very different sort. Now, there are two primary premises to Cuban health considerations. The first is that health is determined in a much broader arena than healthcare, and that in order to affect the health of a population, it's necessary to deal with issues that normally would not fit in to the jurisdiction of a Ministry of Health. And in Cuba, in fact, they are joint operations of housing, urban development, public health, and other areas of the society. Second premise is that and this is the premise for the development of the country as a whole, is that the conditions for the full development of each are the conditions for the full development of all. That therefore the country as a whole has to progress, and that people are dependent on each other. The second premise, which I'm not going to talk about today, is a Marxist philosophy of science with an emphasis on holism, connection among phenomena that seem to be unrelated. Historicity, the inseparability of the social and the biological, the constancy of change. Well, this is the general background within which Cuba has been dealing with problems of health and health service. So the first question is, does it work? The annual public health yearbook for 2011 just came out. I picked it up on my recent trip. And it has data on the usual things you'd expect to find. Infant mortality in Cuba has dropped below 5 per 1,000 live births, which places them at first rank in the Americas, certainly better than the average for developing countries, but also doing better than countries like the United States, which are economically advanced and socially backward. So for the industrialized countries, the average is 5. The United States at 7. Canada 5. Then for neighboring countries, Dominican Republic, 22, Costa Rica, 9. For Latin America and the Caribbean as a whole, 18. Mexico, 14. And the world's best records are in Denmark, Japan, and Iceland, where it's 2 deaths per 1,000 live births. Similarly, low birth weight in Cuba is 5.3%. The question of equity can be detected by looking at the variance in outcomes among provinces. And that variance is less than the variance among states in the United States, counties, prefectures in Japan, provinces in South Korea. So there's really a reduction in geographic variation in healthcare. There's about a 10% difference between rural and urban throughout the country. Now, data of this kind is suggestive. It's not sufficient because sometimes the variation occurs on a finer scale. The data I have is by province, but within the province of Havana itself, there are municipalities which vary more than the averaging that I've given. So we ask, well, how is this done? It's not simply by guaranteeing access to doctors. First of all, the decision was made to base their program on primary health care. So each neighborhood has a clinic, the consultorio, with a doctor, a nurse, and apartments for both of them. It's important that the medical providers live in the same district that they're serving, get to meet the neighbors in different contexts. For instance, in one neighborhood, the neighbors decided that they wanted evening clinic hours. Usually the clinic hours are in the morning and home visits in the afternoon. So they worked out a deal with the local doctor to babysit for her on Monday evenings and have the clinic open. But when people are interacting at lots of different levels, it's possible to understand the needs of a community better. There are 1,000 such consultorios in Cuba for a population of 11 million. So each is serving an area of about 1,000 people. They average about 7 visits per year per person. The cost of this system is 438 pesos in the last budget. The peso on the international exchange would be about 20 to the dollar, 25 to the dollar. The health system is funded out of a national budget. So you can't even talk about insurance. The Ministry of Health goes to the Cabinet and the National Assembly Commission to state their needs, and then there's some discussion about what's possible, what's available. The income for the government comes from the profits on government-owned production. There's some taxes now on private businesses, and there are fees for foreign patients in the Cuban medical system. There's been some discussion about this. Some people don't like the idea that medical facilities are made available to foreigners. Others argue that it's the fees gotten from foreigners which help fund the system. It's every 3 years, the local consultorio conducts a survey of the health needs of the community. And that includes, in addition to the usual things you'd expect in a health survey, immigration and emigration rates from the neighborhood, dependency ratio, the proportion of self-employed workers, the percent of homes in poor condition, rate of attempted suicide, number of micro-garbage dumps in the neighborhood, frequency of garbage collection, cubic meters of water per capita, and a lot of other things of the sort that you wouldn't expect in a health survey. Then after the survey is conducted, there are community meetings, and it's there that priorities are decided for the coming 3-year period. Each of these consultorios is affiliated with a polyclinic. There are about 15 consultorios to a polyclinic, which serves a catchment, therefore, of about 15 or 20,000 people, provides the higher level technical care and facilities. In addition to this, There are specialized facilities like the prenatal service. There are, I guess, 11 prenatal screenings per pregnancy usually. There are the specialized services so that everybody who needs dialysis gets it. The Center for Neural Rehabilitation, maternity homes. There are about 80 cases of autism in Cuba, and that was sufficient to justify a program for the training of specialists to work as teachers with autistic children. There's widespread health education in the elementary schools. In recent years, we've seen a lot of CENEX, the Center for Sexual Education, which besides educating, has also been in the forefront in agitating for changed legislation. So recently they were successful in getting the Ministry of Health to agree to include sex change as one of the available services of the public health system. There are about 70,000 elective surgeries in Cuba per year, including abortion and sex change. There are special associations for service to the blind, deaf, and incapacitated. There's a news program in sign language. On my last trip, I noticed that they were breaking up the sidewalks in downtown Havana to install wheelchair ramps. There are about 50 journals in the medical information system. Now, in 1994, the economy collapsed, and there was a question of whether they'd be able to keep up their program in public health and in other things. The municipal government of Yaguajay, that's a city of about 60,000 people, decided to make positive health in the sense of Alma-Ata the focus of their development for the coming years. In order to do this, they had to, first of all, conduct a survey, and that included such things as dysfunctional families, rates of smoking, alcoholism, proportion of ex-convicts in the population, a very wide range, evaluation of housing quality as poor, medium, or good. From this, they instituted workshops to train people who would be relevant to these programs in health, construction, and so forth. And they realized that this requires the participation of so much agencies of the government at the national level that it could only be coordinated by the municipal government. And so the municipal government stepped into the leadership. Part of their role is mobilizing the resources of the national ministries in the service of the local program. And then finally, this took place at a time when the government was instituting municipal university centers as a way of bringing higher education to the communities without having to move so many people around to Havana or Santiago. So that's an overview of the program. The program has lots of problems. As you'd expect in an economy that's poor, the high-tech facilities are available, and anybody who needs dialysis can get it. The food in the hospitals is lousy. There are times when they run out of toilet paper. So life is difficult, but not in a way that's life-threatening. And people generally have a sense that they're participating in something that's worth joining in and working on, and it's the community participation which makes the system viable under conditions of economic stress and political stress. So that's the experience that I've had in working in Cuba over about 45 years, also working in agriculture. Yes, the Ministry of Agriculture wanted to guarantee a food supply for the cities. At the same time, the Institute of Nutrition wanted to change the diet in favor of vegetables. The Department of Labor wanted to guarantee employment at a time when factories were closing down for lack of raw materials. So all of these interests converged on the urban agriculture program. And now for 11 million people, they produce about 3 million tons of fresh vegetables a year. These are spread out around the city. Some of them will be a whole city block run by a union. In other cases, it'll be a backyard, and people will just be growing 2 or 3 bunches of bananas for themselves or their immediate neighbors. It was realized that you cannot trust rice production to any one region of the country because a hurricane can have a diameter of 200 kilometers. And so there's been the Popular Rice program asking people to grow rice even on small plots. The yields are less, obviously, than in the large farms with experts, but they'll now be able to produce about 30% of the rice needs of the country. Some of you have seen reports about Cuba importing 80% of its food. Well, that's really nonsense. It's 80% of the grain. Wheat doesn't do well in the tropics. You have to have a special program, and they haven't done it yet, to develop wheats that would be suitable for growing on a large scale in Cuba. So they do import a large proportion of the wheat and other flour, but for the food as a whole, it comes to, I think, maybe 30 or 40%. There's a lot of roots and tubers, an increase in production and planting of corn. But the really important change is the change in the diet with the increase in the availability of vegetables. So that's just an example of the way programs fit together in such a way that it would be difficult to ask what proportion of this effort can be assignable to this ministry or to that program. And that's something which Cubans wouldn't worry about, as they don't worry about the question of whether my neighbor is getting more than I'm getting. When paint became available a number of years ago, a small amount of paint, the question was how to distribute it. At that time, there were going to be big festivities. I think it was in Santa Clara. And so they agreed that it would make more sense to put all the paint in Santa Clara where it would make a difference instead of having a daub on every house in the country. So that's the kind of thinking they do. They also seem to have a Minimax strategy, even though they haven't labeled it as such, which is when they look over the statistics for the healthcare results, they'll focus on those places that are doing most poorly and concentrate there. So they're able to mobilize in a hurry, for instance, when there's an outbreak of dengue or when HIV first appeared in Cuba. There is this flexibility that you don't have to really engage in negotiations with different institutes. They know each other, they've been to school together, they have common goals. There's no question of patents and privacy of information, so people work together. When I had a scheduled meeting on my last trip with Castro, which didn't come off because of the death of Chavez, but the interesting thing about it is that all of my friends working in different institutes knew about it, that the grapevines in Cuba spread information very rapidly and very effectively. So now, why am I here? When the question is, how can we adopt the Cuban method of public health? And I don't think that it can be done in a capitalist country. And so in a way, the experience of the public health system is also a political argument, which I can't engage in here, but which is one of the basic reasons why I've been a third-generation communist.